Hey Devesh, how you doing? Thanks for coming again, boss. Okay. I hope I can just automatically set this up. Danny, do you have the ability to admit people or no? Okay. All right, we'll give it like 2, 3 more minutes. Let everybody keep joining. I have to manually admit them, so bear with me. Hey, we'll give it 1 more minute. Hey, Diana.
Hey, how are you?
Good, good. Congrats on your TY acceptance. That's big. I'm happy for you.
Thank you. Thank you. So I'm excited too.
To start up. Okay. Okay, I think we'll go ahead and get started. We have a good amount of people here, and I'll try adding them in as we go. And Danny, I don't know if you can hear me, but if you get a notification that you're trying to come in, then let me know. Okay, so I think this is the most important part of intern year, which I think is case reports. I think case reports is going to be the bulk of your research intern years. This is where you're going to do most of your publications, most of your presentations, your poster presentations. When you're in second year, you're going to try to upscale it, but at least for your first year, you need to know how to do case reports, whether that's poster presentations, whether they get accepted as abstracts. Everybody needs to know this as an intern. So, okay, I have no financial relationships, ACP. They do not pay me to do this. I do this for free and voluntarily. Okay, so how do you know a case is good enough? I think this is everyone's question. This is the big thing that everyone always asks me. How do you determine it's a good case? And most of the time, you don't even know it's a good case. It doesn't have to be. Everyone thinks you need to find like that new disorder, that new, you just discovered a new mutation or this new syndrome that, you're going to win a Nobel Prize for. It's never that. You're never going to find that. I mean, hopefully you do one day, but you're likely not going to find that. That doesn't mean your case is not novel or rare. And I'm going to go into how you can make your cases novel or rare. You can make anything a case report in this day and age. Anything is write-upable for the most part. And then the other part is where I think everyone should be able to do case reports, and that's deviating from guidelines. As long as you understand guidelines for whatever that current case is, whatever it's heart failure, GDMT, as long as you do some type of deviation from that, you explain why you did it, it was ethical, and it showed promise, like you avoided harm or whatnot, that's publishable. That's all people need to see. All journals need to see is something that can go to guidelines, change guidelines, question guidelines, prompt new research. So don't worry about finding the next big thing. And I'm going to teach you guys how to do all these things. I need to make this automatic going forward. Okay, so novel cases. Obviously, you're identifying a new syndrome, a new disease, adverse drug reactions. That's all novel. Like for example, beta blockers. I don't know, causing headaches, that's a new drug reaction that just came out, and you could publish that. Unusual presentations, maybe you have a heart attack presenting as left toe pain. That's the only symptom she had, but she had a STEMI, publishable. Novel diagnostic use, that's like using things at your disposal for like diagnostic criteria. Like POCUS is getting a lot of attention now. But those things are a lot harder. And I want to teach you guys how to be able to make your case novel, even though you won't feel like it's novel. I'm going to show you how you can do it. So it looks like it's the hardest thing to do, but all you have to do is, for example, you combine diseases, you combine syndromes. One can be rare, but it's like readily explained about. And then you have another like overlying pathology that's also rare, but you've never seen them together in the same inpatient admission or whatnot. You can combine these things, and that's easily presentable. That's changes management. Maybe there's something to do. There's a relationship between these two syndromes, and I'm going to show you examples, not that I found on the internet. I'm going to show you examples from our institution that we've done, that I've personally worked on, where I can just publish these things. You can highlight differences in diagnostic criteria. So, for example, like in heart failure, there's a Framingham criteria, or in DKA, there's a good example is actually DKA, how euglycemic DKA was SGLT2s. Those are cool things. Those are things that are publishable, and that's just differences in diagnostic criteria. And then unexplained presentations. Usually, a good one is the STEMI presentation. I think like in the last 10 years, atypical presentations of like women, having STEMIs and heart attacks, whether it was GERD, right upper quadrant pain, that's all they had. And, they had STEMIs. It was like a big deal in cardiology, but things like that are publishable. And that's novel. You don't have to find a new syndrome. So as long as your case, your presentation, your diagnostic criteria, these two diseases overlap, as long as it doesn't follow the typical rules of that disease, like what you study for your boards, that's publishable. And I'm going to show you some examples of that. So this was a case in our institution. It's Wolff-Parkinson-White syndrome, which is very well understood. There's tons of papers on it. And then this patient had a congenital inferior vena cava anomaly with a zygos continuation, both very well understood, but you've never had them together. And just for proof, we did a little literature review. This is a very basic one. It should be a lot more in depth than this, but you go on Open Evidence. When you guys get an NPI number, when you're residents, or if you already are, you can use this and you'll get a lot of stuff. But there's no reported cases of this. So this was novel. This is just something that was easily publishable. It wasn't anything crazy. And it did really well. So, and why is it publishable? Because it's just a rare anatomical variant. And it changed planning because he had Wolff-Parkinson-White syndrome. That's all you need to do to combine these things. You have two cool things, combine them, and you can publish it. Does anyone have any questions so far, by the way? I know I'm talking maybe too fast. Okay. And you can combine anything. I know a really good one that the ACP had, Zane Barakat. She combined like two different cancers in one patient. We call those collision carcinomas or whatnot. And her paper did really well. So just find anything to combine, and those things are easily publishable. Here's another one. Common diseases with unusual presentations. Zane had endometriosis, and it metastasized into her thoracic cavity, which is super rare. There's very low documentation of that. But endometriosis is not rare at all. She just found a rare position for it. This one, the migratory mystery. All I had was a patient with combined histoplasmosis, blastomycosis, very well understood. You guys all know what that is because you're boards. But the patient was in Florida. That's not here. And he migrated from South America, was immunocompromised, and came to us. That's all it was. And ID Journal took it because it was all about the immigration journey. I don't know if many of you know, but there's a lot of immigration coming from South America through Mexico to Florida. But and this patient sits on our lap. We're in Florida, and he has blastomycosis and histoplasmosis. Not our differential. We don't deal with that a lot here, but just knowing his journey was enough for us, and Chess loved it. Here's another one. This one's awesome by Voska. This one did really well. This one got into Jack. So we had a patient who was morbidly obese. He was huge, And then we just got a lipid panel on him, and his LDL was like 30. And I remember me and Vasu, we were upset. Like, how is that possible? How is he so healthy? My LDL is worse than his. So we started looking into it, and ApoB, ApoA1, they're trending right now. So we just got the labs. Our attending let us. They're very expensive. And it turns out the guy has like a genetic advantage over us. He's so obese he couldn't even get up off the bed. But his LDL is amazing. He has no coronary artery disease, and it's hard to understand. And that was awesome for us. It was as simple as that. There was nothing rare about this. Both ApoB and ApoA1 are well understood. Obesity is well understood, and atherosclerotic disease. So this is just examples of how you can do novel things. Haiti syndrome, that's not publishable anymore. Everybody knows what Haiti syndrome is. But this was Haiti syndrome after the patient already had a mechanical valve replacement, and we couldn't do anything about it. Had to stay on anticoagulation, still bleeding. Jack took it. Jack loved it. Jack had never understood, this. So these things are interesting. So this is how you can just find novel things that's not in the literature, but that are really well understood. You don't have to become this scientist to do case reports. Just find unusual things in usual things, and you'll be able to publish anywhere. At least you can get this into conferences for posters. This was another one by Omar, adverse effects. Simple. And AJG took one of the best journals for gastroenterology, which was just mesalamine use causing bradycardia. There's only one, when we did the literature search, there was only one case ever reporting this, bradycardia and mesalamine. And I remember when we were, in wards, we thought this was, why are you going to publish this? And it's as simple as that. It's something novel, and it means nothing. Everyone uses mesalamine. Bradycardia is well understood. Crohn's disease is well understood. This is all you need. Just find something different. Every case has something that you can tailor it to publishing. So don't think you need to find the next Nobel Prize winning project, especially as an intern. You're going to have 1 year, and your time in wards, if you're doing internal medicine or whatever it is you're doing, whatever specialty you're doing, is limited. You're not in your specialty all year. You have electives, you have other duties. So find a case, look at the guidelines of that case and see where you can deviate, what you can do different. And I'm going to show you how you can deviate from guidelines and publish things now. So this is another one that we did with Omar. The funny thing is, I saw this case with one of my mentees, Vasu, and he didn't want to write this up. He said there's no way GLPs are causing SMA syndrome. I mean, from what we know from SMA syndrome, you get bariatric surgery, you lose a ton of weight, right? And that's how it works. What if you don't have bariatric surgery? Now GLP-1s are incoming. We had a patient that lost a significant amount of weight, has SMA syndrome, and we were just restarting the home medications, and I saw there was Ozempic. And I said, could this be it? He said, no, I'm not writing this up. I gave it to Omar, and this case is going to do extremely well. There's no cases of this. There's no reports of this. There's a lot of research right now in GLPs. He submitted it to ACG, and this is simple. We know everything about GLPs. We know the side effects are like pancreatitis, gastroparesis, nausea, vomiting, whatnot. That's all we really know. Some thyroid issues with MEN2A, and SMA syndrome really is just associated with rapid weight loss, like bariatric surgery. So are GLPs now, can they cause these issues in patients that lose too much weight? Who knows? There's no documentation of it, but that's what we're going for. So it's things like this where now you have something novel. This is, and actually I think he presented this at SHM, and he might be getting emails from some companies. Sometimes they ask for like proof because they get upset, but this is an example of novel stuff that doesn't look novel at all. Okay. But before I go into guideline deviation cases, does anyone have any questions on like novel cases, things you can do to appear novel? Do we all get that? Just interrupt me if you guys have any questions, okay? So guideline deviation. Not every publishable case needs to be novel. So besides finding what we found, in all these other cases, as long as you challenge the current guidelines, not all guidelines are up to date. Not all of them are up to date. Some go as far back as like 2011. There's going to be new medications coming in. A lot of different things are happening, interactions with medications where guidelines are going to have to change, okay? So I'm not going to show you how to find cases like this. I think this is the bulk of at least the cases that I've been able to publish. Maybe just because I'm curious, but this is, you'll be able to run into this a lot. So these cases are not novel. So all you're doing is challenging the current guidelines, and you're proving that your deviation, you went away from a guideline, but it was ethical. You had a reason to, and you had to have some sort of a positive outcome, whether that was a benefit, you avoided harm, or you showed why the guidelines may need some changing. So it's easy. You start with a standard diagnosis, just, I don't know, headache or chest pain, right? And aspirin use. You're going to handle it differently. Every chest pain comes, you know, ACS, you're going to put on DAPT, dual antiplatelet therapy, I don't know, heparin, they go to cath lab, blah, blah, blah. You're going to do it differently because you want to deviate from the guidelines. Now, you're not going to do anything that's going to kill them. You have to have a reason to, okay? Maybe they're allergic to aspirin, Plavix, and heparin. Who knows? You're going to document why you did differently, why you had to, because it has to be ethical. And then you're going to say, what happened? Did the patient have a better outcome? Did he avoid harm? Is there a limitation of the current guidelines? Do I have to use aspirin Plavix? Can I use aspirin Brilinta, which Brilinta is not first line, but can I use, you know, Cilostazol, anything, any other antiplatelets? You know, what can I do that's different that shows that it was better? And you need to support it with literature. If you are not the first person to ever deviate from the guidelines, you need to cite every case that's ever done it and how their case was. And I'm going to show you an example of what they did, or at least what I've done with that. So this is a first example. This was with Jessica from the last journal club. And this was a super simple case. Again, we didn't think it was, you could write this up, but so this is MRSA bacteremia with osteomyelitis. This is the most common thing you're going to see as an internal medicine resident wherever you are. Doesn't matter, you're going to see bacteremia and osteomyelitis all the time. Well-established conditions, we know a ton about them. We have good guidelines on them. We know that you should get, if it's MRSA bacteremia, you're going to get IV Vanc, 6 to 8 weeks, depends. They'll give you a PICC line, and you go outpatient. Why? Because it's expensive to stay in the hospital, and you can get your antibiotics outpatient, better quality of life, and whatnot. So we know that's the treatment currently for MRSA bacteremia, when you have extended outpatient antibiotic therapy. Now, what happens when we have a patient who has a PICC line, he uses meth, he's probably not going to come back because he leaves against medical advice every day. We know he's going to abuse the PICC line for drugs probably because he's done it before. So, and is he ever going to come back every single day? Is he going to come to the ED or to the clinic to receive his dose of vancomycin? And is it fair to that person to allow him to do that, for us to, you know, give him a PICC line where he might just get more infections? We know he's not going to be adherent. So we know dalbavancin is a medication used, it's basically like once weekly Vanc, it's the same thing, but it's only approved for MRSA cellulitis. That's skin infections. That's all it's approved for right now. It's going a bunch of other trials, like phase 2B trials for MRSA bacteremia. But we were in the hospital and said, how about we just have him come back once a week, and that's 5 visits. We give him his dalbavancin. At least he'll be more adherent. He won't have to come every day. We know he won't need a PICC line, and we know he won't abuse it for drugs. And that's it. It was an off-label use. It was ethical. We had a reason to do it. We have had proof that he abuses it, and we used dalbavancin instead. And it worked out great. He had a cure. He came to all 5 visits. The MRSA was gone, and we were able to publish it. And it's something that we didn't even think was anything cool. It was just a social issue. Another example of just deviating from the guidelines. When you have a PFO and you have a DVT, if you have a PFO, that stroke can come from the venous side, cross over to your arterial side, and you can have a stroke. We call those cryptogenic strokes, okay? We had a patient that, based on his rope score, we should have closed it, but he was too elder, okay? And he had a stroke. So at that point, we just used anticoagulation. But the next day, his stroke converted to hemorrhagic stroke. So now we can't use anticoagulation. So what do we do for this guy? And then the guidelines right now for PFOs and cryptogenic strokes, they don't really talk about IVC filters. Obviously, I think a lot of people would have put one, but not really much explained in the literature. So that's all we did. We put an IVC filter and we put in the literature, hey, in patients that are too old to undergo these procedures and anticoagulation is not recommended, just drop an IVC filter, at least meanwhile. And that was publishable. This got into a cardiology journal. So you don't have to be this crazy scientist. Just see what the guidelines are when you're treating someone, when you go on UpToDate, when you go on Open Evidence, see how you treat PFOs and see if you and your attending did that. And if not, was your way better? Did it work? And if it did, then that's publishable. That's all it takes to publish something, deviating from the guidelines. That's all you have to do. Before I answer this question, does anybody have any questions of what type of case reports to find? Or any questions about deviating from guidelines, what's novel, or anything like that? Okay, now I'm going to go into big hurdles that everyone has with case reports, and that's, I think this is an important question, especially for ACP. How do I find, Mike, how do I find a case if I'm not even working in a hospital? I'm not a resident, I'm just a med student. I think this was my problem too when I was like a third year, not a fourth year, rotating at a hospital. I know there's some IMGs, there's some people that are time off away from the hospital. So the best thing you can do is honestly just cold email. Find residents, attendings. Attendings have a million case reports. I remember when I first went to Lakeland Regional, they didn't have residents. We were first year there. They had so many cases for us to write up. And it just sits on their minds. They keep these MRNs of these patients. They have a bunch of cases. Email them. Find attendees. Just email. Say, hey, do you have any cases you want me to write up? I know you're busy. That's it. And I promise you'll get case reports out of that. There's residents that are too busy, or they have cases, but they're not that interested in fellowship. Just email them. No resident will get bothered about an email. That just cold email. Find them. Another thing you can do that a lot of people don't know about, if you're fascinated by like rare cases and you find that there's like 3 in the literature, but there's no case series, even though you're not part of those cases, you can just combine them and do like a case series. And it's honestly like it's legally stealing a case. You can get all 3 cases. Let's say you find 3 cases of, I don't know, Coca-Cola curing headache, and then you do a case series. Well, as of today, 2025, Coca-Cola has been shown to clear headaches in patients that are diabetic. And now you have an easy publication like that. That's an easy way to get a publication. It's almost doing like a meta-analysis for randomized controlled trials or like a literature review, but instead of trials, you're just doing case reports. So it's a case series, and you can do that. You don't have to be a part of those cases. Those cases are already published. They're public, so you can go ahead and access them. And it's that simple. Now you have to ask for permission to use their figures, their tables, but email them. Email them, give them authorship, and tell the authors, hey, I'm going to use your case for a case series. Is that okay? Do you mind if I use some of your figures? No one's going to say no. Everyone wants to get published. It's easy publishing. I have a question here from Dr. Isaiah. Yes, it is being recorded. Please do not deviate from guidelines in your treatment. Yes, do not deviate from the guidelines on purpose just to get a treatment. It has to be ethical. That's the whole point. You have to have a reason why you deviated from it. Otherwise, either way, journals, even if it turned out good, journals are gonna say, well, why'd you deviate? It's like shooting darts. If you do a different treatment for, gastritis, obviously some other things may work. That doesn't mean it was the right thing to do, okay? So that was a good point by Karasik. Let me make sure I'm recording here. Yes, it's recording. Okay. Does anyone have any questions, by the way? so far about how you can find a case if you're not working in a hospital?
Mike, I have a question about, sorry, about like how you can tell if a case is novel. I feel like I struggle with like knowing what number of case reports published is like a lot or too little. And I don't know if you have a specific number for it, but like, is it below 10? Is it below 20? Like, what is the number that you go by to say this may be a good case?
Yeah, so the best thing you can do is if you have a case, for example, GLPs on SMA syndrome, let's say there was like 5 cases on it, or there could have been 20 in the last year. As long as that I'd feel comfortable publishing as long as that there's no case series on it, or there's no literature review on it. Because once there's a literature review, there's some type of, people are compiling these studies. There's actual data, people are looking into it. As long as you're not at that level where there's reviews, there's a methodology to these novel case reports, I think you're fine. The number doesn't really matter. Just look for like trials on it. So if there's a trial, looking at GLPs and SMA syndrome, I'm not going to publish it as a case report. I'm just not. My case does nothing for it. You're looking at a big trial that's really going to look at it. If there's a review on a case series on it, I think your case report is dead at that point because they already have a full case series and whatnot. But as long as there's just case reports, you're fine. Because if it's something worth publishing, you'd have a series on it, you'd have a review on it, you'd have some type of trial going off of it. So I think just look deep and see. If it's just case reports, I think you're fine. And for sure, less than 10 is really good. That's amazing. I have another question here. Can you talk more about case series? When does it make sense to consider doing a case series? Do you need permission from every author? So you don't need permission to use any type of published research online. You don't need to do that. If you're going to use their figures, yes, you need permission from them to use things that they've created. But you can use their data. It's published for a reason in the public. That's the whole point of why we do reviews and meta-analysis. When do you decide to do a case series? If you have a cool case and you see there's like 4 other cases, and I'll show you now the dalbavancin one that I did actually. There was 4 other cases. I didn't think about doing a case series. I just did the case report. But I probably could have done a case series also after that. Or maybe someone who's reading this can think about doing that. I'm not sure. But case series is an easy way without having your own case to compile cases. That's all I'm saying. It's a little cheat code. It's the same thing as a review, but for cases. Anytime you have an idea, just go for it, okay? There's no right or wrong answer. And usually if you can go into the journals where those cases are, or that specialty-specific journals, they'll be more willing to take you. Any more questions about that? Yeah, thank you, Karasik. So another thing you can do, shadow, volunteer clinics, hospitals, you guys know that. Offer writing services. Honestly, just tell people, hey, I write. You have no idea. When I go to conferences, and this is not for anything, and you don't have to do this for me, I am still going to be your mentor here and your friend. But if someone comes up to me, introduces me and says, hey, I can write for you. I know you're busy. I know you got a ton of stuff. I'm really good at writing this and that. That person to me is golden. You have no idea how much doctors, we don't have a lot of time. Our time's limited and nobody likes writing. That's just the truth. If you can have people dedicated to these research years at other institutions where they just offer writing services and they get authorship, that's the best thing you can do. And it doesn't look bad. I don't need anybody to tell me that they are a great resident or a great doctor. Research is research. Just tell me you can write, and that's fine with me. You're on board. Let's go. Let's get this done. So offer writing services. Research internships, applying to programs. There's programs that do 1-year stuff for that. They'll get you a ton of research and whatnot. Okay. Once you got the case, you wrote it. Now we're going to make the poster. So in the last 5 years, every single big conference like ACC, they give you templates, and now they're leaning more towards a central design where you have words on the left and right, and in the middle you have your results, figures, tables, infographics, and whatnot. Sometimes you're not gonna have space and you have to put stuff on the side, but your poster, central's better. And bigger is better. Zane, actually, when she won the first year ACP, they gave her like a size range to use, and she used the utmost biggest size. Her poster didn't even fit the template. It was so big, and she won. I thought that was interesting because last year Vasu did the same thing by mistake. So his poster was huge, and he won, and his was the biggest poster there. I'm not saying anything, but make your poster as big as you can. They give you a range like 36 by 48 to 56 by I don't know what. Just pick the biggest one. It'll just, people will eyeball it more. It's all psychological. They're just judges at the end of the day. So central design, bigger is better. Make it as big as you can. Less words. You want to have as many figures, tables, infographics as you can. You have to remember that you presenting your poster, they're not even looking at you really for the most part. They're looking at your poster, and your voice is just kind of like an adjunct. Honestly, they probably phase you out, and they're looking at your poster to see how you can make your poster make sense. So your poster should be able to tell a story. Picture yourself walking away from your poster. You went to go get water, and they're just there. You come back, and there's nothing you can tell them new about your study. They understand it. That's how you want your poster to be. And then references, don't label them like that anymore. Just use QR codes. It looks cooler. It's fancier. That should be the new way to go. Any questions about poster design? Also, you don't have to follow this. There's no rule. If you want your poster to be a certain way, do your poster exactly how you want. If there's no questions about posters, I'm going to move on just real quick. I'm going to show you some examples. By no means are we at LRH the best poster presenters or anything like that. I'm just going to show examples of what we've done because I don't want to use anybody else's. I haven't asked anybody for permission. So you see a central design. All you have to do is quickly look in here. Yes, Karasik, you're right. Every organization, depending on your residency, they have their own design. So for us, the top is what we need, which is the NSU on the right, Lake Learning on the left. That's pretty much all Dr. Lugo requires of us. For the most part, we can format it any other way we want. But yes, keep the middle. You want them to be able to see your poster. You have your results there, and in big, you just know everything you need to know about the study. See central images. Question by Kumar John. Let me see if I can read. Yes, Kumar, this is being recorded, and Dr. Isaiah, along with the team, they usually post it, I'd say like in a few days, like 3 to 5 days. But I'll release an email, and I'll probably send this out too. But I think it'll be broadcasted on YouTube or whatnot. This was by Vasu. See, we try to keep it central. Everything central, QR code with references there. This was the one that won this year by Vasu. And then this was the one that won last year with Zane. And then this is another one that we have. So this is not a case report, but I wanted to show you guys this right here. You guys can make these infographics. I think this was made by ChatGPT. I can tell. Yeah, it was. You can easily, and this is not made up stuff. This is our study. But you can tell ChatGPT to make you an infographic, to make you a flow chart, and anything, whether it's a flow chart that's on up to date and you don't want to copy it, you don't want to cite it, make your own. Like, do your own flow charts. This makes your poster look good. It lets people interpret your poster, okay? Okay, this is another big thing that this is something I dealt with a lot with the new interns. So they'll come in and say, hey, they'll just give me an abstract to review that's just words. And the first thing they tell me is, my case is different. There's no figures, there's no tables, there's no imaging. This is just a presentation. You can make figures and tables out of everything, okay? If you have lab values, which you do, I need a table of it. You should be able to put that, whether from when they got admitted to the end of their treatment or whatnot. Just show me some lab values. I don't care if it's one thing, whether it's a white count, whether it's a hemoglobin, pro count, I need some type of lab values. You can easily put that. Vitals, depending on the, your case, but you can do the same thing on admission, towards the end, or daily. Even if it's a medication list, if you're talking about adverse effects, just drop a table of the medication is, as opposed to writing patient is on Eliquis, pantoprazole, oxycodone. Just make a table for it. The hospital event timeline will happen day 1, day 2, day 3. In summary, differential diagnosis. You don't have to word that as in a case presentation. You can actually just make a table of it. If you want to compare guidelines, so for example, ACC and European ESC, they're like the 2 biggest cardiology societies, but their guidelines differ a little bit. So if you're doing a cardio-related case, you might want to have both guidelines, like pictures of the recommendation for, I don't know, SGLT2s and HFpEF, which is like a class 2, 2A recommendation here in ACC. I don't know what it is in Europe, but you can have those things, and it adds color. It just brings your poster to life. So there's always things you can do for tables. Always. Never just don't submit something blank. That's like the easiest way to get rejected for a good case. That everyone that reviews these things, they just want to see that you have something nice. Figures. There's tons of figures you can use. Besides radiology, if you have physical lesions on your patients, take pictures, EKGs, procedure images, so like colonoscopies. All those things are on Cerner or whatever EHR you use. Histology, pathology slides. You can walk to the histology section of your hospital, and those people don't see humans. You can go in there and ask them, hey, my name's Mike. Nice to meet you. I'm interested in this slide that you made. And they'll love to show you. And you can use 2 figures. Compare that one to like a normal tissue. And now you have 2 figures. You can make a figure for like the progression of the disease as the lesion got bigger, pictures. You can use the mechanism of action of GLP-1s as a picture. That's, as simple as that. The mutation, whether it's, I don't know, how the drug acts on receptors. You can do flowcharts for diagnostic and treatment. So how you treat hyponatremia, if it's, serum osmosis, hypo, uvo, all those things. There's so many things you can do for cases. You should never submit something blank, okay? And if you have lab values and you don't want to just write them, you can turn them into graphs, line graphs, show a trend of the white count, or use bar graphs, whatever you want. Does anybody have questions on this? On like what tables, figures, and things they can use? Okay. So you did your poster. Now we have to publish it, right? This is I think where 90% of residents leave their study. And our posters cool? Yeah, they are. Some people don't ever do posters. But you don't want to just have a CV where you just have abstracts, poster abstracts. You want to have things where you turn abstracts into publications. This was a big thing actually when I went to the American College of Cardiology conference last year. And all the posters after the end, everyone just got them and threw them in a garbage can. And the CEO of the whole conference, he took a picture of it and he put it on Twitter, and he said, it's, I remember him saying, it's so sad to see all these posters not turning into manuscripts. So they do look at that. And it is sad. If these conferences take you, it's because they think you're contributing something. So they'll just leave it as an abstract. If it's an abstract, remember that conference is publishing you. When you go to apply to a PD or fellowship, they're gonna say, oh, well, you published this abstract, you went to Vegas to Society Hospital Medicine, you put a, nice little abstract together. How come you didn't publish it? What do you just wanted to go to Vegas? You just, why, if this was so good, you have your citations, it's pretty much done. Why didn't you turn this into a manuscript? So you don't want to be that type of resident. It's going to hurt you. It's going to haunt you. A couple abstracts is fine, but you want to learn how to turn these into manuscripts. And I know this is the hardest part, but I'm going to try and help you guys get there. So I know that the biggest hurdles are money. I think the biggest thing is money, time, and then language editing. So for money, don't think that Curious is bad. One, if you're a resident, you should have some program support to help you pay for journals. That's fine. Go for other ones. If you don't, and I know that happens. Some programs just don't offer research support. Then you have to go to Curious. That's something you can explain in your in your interviews or whatnot. You say, I didn't have support, you know, and I'm on resident salary. We all know resident salary is not good. And that's okay. Curious is not a bad journal. They're PubMed index. They're super fast. So go for Curious. You can also go on Schemago. I love that site. And you find journals that are subscription based. That means they can't access the full thing. It'll be free. But you don't have to pay, and you still have a citation. It still goes on your Google Scholar, but they'll only be able to see the abstract. But who cares? You know, for the most part, your case was not going to change the world anyways. No offense. I hope it does. But we're just residents, and it might not. At least not now. Maybe in the year. When the year becomes open access, and they'll see your case report. So just don't pay for it. You don't need open access. How to get the poster published in Curious. I've seen some. The poster, oh yeah. So good question by Mohammed. He says that how do you get the poster published in Curious? So at least from what I know, my institution's affiliated with NSU, and they have like a, I don't know, it's like a section that you have with Curious. There's a lot of institutions that have it, and they publish your poster there. We do have it with NSU. It just depends on your med school and your program. It's not, I don't know how it works or who's eligible, but some people are eligible. They will publish your poster there. And then I have another question. Yes, Curious still costs money, about $700. And then those of you who are part of HCA, they don't approve publication in Curious anymore. That's interesting. I'm sorry then. I don't know. I didn't know that HCA hospitals do not approve publication in Curious anymore. I don't know if that's true or not. I have to verify that. But I know $700 is a lot. So the best thing you can do is go on Schemago and find journals that just offer subscription services. They're free. They'll publish your abstract and just wait a year. If money is the issue, then that's all you can do. Unless you offer, what you can do is offer authorship to people from other institutions that have good funding, you know, and that's unfortunately kind of like the life with research that we have as residents and whatnot. But I think this is your best bet. Another thing, submit to the conferences that publish you. So an abstract, so if you submit, for example, to SHM, they'll publish the abstract very briefly, but it's not the same as publishing an abstract to Jack, right? So if cost is hard, you just can't find a journal, submit to conferences, at least get an abstract out of it. Posters, there's a lot of conferences that posters, they don't publish these things. So find conferences that do publish you as an abstract. And that's very low cost. I think they'll charge like $50 to $70. Some are free. Those are things you can do to save money. So hopefully that helps, but I know money's a big deal. That's why you guys should find programs that have research support. Time. A lot of residents don't have time. There's what you can do is outsource to younger residents. Some interns don't have cases. Give it to them, give them authorship. That's what we do here. I'm trying to build something in this committee where I'm sure many of you are trying to write case reports. We have residents from LRH. I plan to make some type of a form where we can have cases for you guys to help us out with, and expand this across other institutions that are part of the ACP Florida, which I think will be a good idea. Try to make this kind of like a base for cases. But I'm hoping that's what this committee can become later. And then usually if you're in an institution that's affiliated with medical students like NSU, we have like 400 med students. If I really had no residents that could help me, I might just message, I can message the student coordinator there and just say, hey, I have like 3 cases, send them out to your 400 students. I'm sure I can get like 10 to help me out, 3 each. So those are things you can do if you don't have time. Language editing. This one's big. You need to find a PI or a mentor to overview this. Find someone, if it's a cardiology case, find a cardiologist in your hospital. I want to say something about AI that you have to be very careful of. AI is amazing, okay? And there's a lot of research being produced right now. Everyone has research because of AI, but you have to be careful. The best thing you can do is write your case in your language. It doesn't matter if it sounds dumb, if it sounds, low, like you sound low IQ, you're not, you don't sound smart. Just write it, cite it, do everything how you write it. Then you can take it to AI and say, hey, can you formalize this? Reread it and make sure that there's no information is made up, no information has changed, just language editing. Some journals will ask you to disclose this, and you can just put a disclosure. It's fine. It's very common. If that's your issue, you can do that. I don't recommend paying like $2,000 for someone to edit your case when you're not even sure if it's publishable. So, and that's another way you can save money. Okay. And every journal is different. Look at how they format things. They'll tell you exactly how they want it. So don't worry about formatting that much. Just look at the journal. They'll tell you how to format it. Does anyone have any questions about these hurdles?
Mike, I do. So I think like the biggest thing between like changing a case report into something that's publishable is like I always overthink like how long does it have to be? Do I have to make it much longer? And I never really got to look into it much. But what in your opinion, does it have to be much longer than what the case report is?
Like usually it doesn't have to be that much longer. You're just expanding a little bit, and I'm going to show you how to format it. I have some examples, but you don't have to spend much at all. And I'm going to show you how many citations you need, word count, all that.
Perfect. Thank you.
So this is what we're going into now. This is the format usually for your poster/case report. So all you're doing is expanding every single little section into a bigger one. So in your intro, you're just going to talk about your actual problem, whether it's a novel problem or it's a guideline deviation. You're going to have about 40% of your citations here. The case description, this is the easiest part. This is where you bluntly write what is going on. Word for word, everything that happened from day 1 to day 7, chronologically. You cannot skip days. You have to write everything that happened, figures, labs, everything. Just talk about the case. The reader, the journal has to know exactly what's going on. Your discussion is where you compare your case, like, why is it cool? Why should I publish this? What is it adding to the literature? This is where you tell the journal or the editor, this is why this needs to be online. Like, people can learn from this. This is something that we've never seen before. This is something that people need to know because it'll help guide management. It'll help people avoid problems, whatever. This is where you sell it. And this is the bulk of your citations usually, but it could be 50-50 to your intro. You guys know what the conclusion is. References, a lot of people always ask this. Vancouver or AMA style is usually the go-to now. You don't really see APA or MLA, but use your journal guidelines. And then the amount of citations you want is 10 to 20, somewhere between there. Less than 10, it's kind of weak. More than 20 is way too much. But you want to have somewhere between there, give or take. And then for word count, anywhere from like 1,000 to 2,500. 1,000's on the low end, but do not have more than 2,500. There's meta-analysis and reviews that have up to 4,000 words, and some cap at limits of 5,000. There's no way a case report should have more than, really, 2,000 words is a lot. Shoot, again, like for references, 10 to 20 citations, 1,000 to 2,000 words. I think that's fair. Now, I want to show you guys how I did this. I showed you guys the poster for it. This was an easy publication. All I did in the first paragraph, in the intro, and as you can see, I have 9 citations here. I just talked about why outpatient antibiotic therapy, why we do it for people who require it, for like MRSA bacteremia. So that's the first paragraph. I just tell the editor, well, this is what we do for bacteremia. We do outpatient antibiotic therapy because hospital costs, quality of life, you're not going to leave someone in the hospital for 8 weeks, right? Cool. Next paragraph. Why adhering to these regimens can be troublesome. I can do it. I can go to the hospital, or I can go to the clinic and get daily. I can have a PICC line and get, if I had MRSA, I'd be just fine. But there's other people that can. Homeless people, people have to work jobs. What about them? How can they adhere to these regimens? So then I talk about the guidelines. Well, the guidelines say you need 8 weeks, so that's what we have to do. That's what we have to do. We have to do 8 weeks or 6 to 8 weeks. It changes. So what's the, you're stuck now. How do you treat this guy? When the guidelines tell me to do this, how do I help this man who's an IV drug abuser, who is homeless? How am I going to do that to him? I'm going to give him a PICC line so he can shoot up meth there again. So, and in the bottom, I just introduced this new drug, dalbavancin, once a week, off-label use, what it's approved for, and that it's not studied and what I'm using it for. Well, we gave it a shot, okay? And then I'm not gonna put the case presentation because it was long, but all I had was 2 figures, and these are simple figures. All I did was a figure of osteomyelitis, where he had it, the MRSA bacteremia. This was the source, and I just put the deep wound culture with the sensitivities to vancomycin to prove that it's MRSA. You don't need anything crazy. And I didn't write the case presentation because it's long. But, and then in the discussion, this is all you have to do. I only went up to 14 citations. I reintroduced the hurdle. I wrote about 3 other cases that did it. I think 2 or 3 of them failed. 1 was good. How mine was successful, how this addressed an issue, provided a solution, and I was lucky to even find future implications. So they're actually doing a trial on this. While I was writing this, I was looking it up, and they're doing a dalbavancin in MRSA bacteremia trial. It wasn't completed at the time, but they were doing it. So this was the perfect time to like do a case report like this, you know, at least to add as an adjunct to that RCT, or before it comes out, you know, I can do another case report on this. And if you're curious, it did come out already, and it did show. It was completed in December 2024, and it actually showed it was inferior. It was non-inferior to vancomycin. So this might just be guideline change. I'm not saying it was my case report that changes. This RCT was already going on, but you know, these are cool things that you know, a case report that I thought nothing of, and now you know it's part of something that you know might change for you guys when you're residents. You might just do weekly dalbavancin as opposed to vancomycin. Who knows? But that's just how you'd write it. You bring these things to life, and that's pretty much it, guys. Do you guys have any questions? This is how you take a case report from poster. You go around all the hurdles, and I know you guys probably have a lot of questions that you're not gonna ask here. Well, you guys had a lot, but email me. Please email me. I can help you with anything. I don't mind reviewing stuff. If you need cases, I can connect you. I'm gonna build something for us to, you know, for everyone to have case reports done, reviews and whatnot. I want you guys to reach out to me. I want to be able to help you, not just for these presentations, but for anything else you need. Okay. I know a lot of you are going to start residency soon, and you're going to have a lot of cases, and you need help. So please feel free to reach out and scan this and give me some feedback. Okay, I'm getting some questions meanwhile, but please scan this. Many journals and institutions require a signed patient consent for approving or publishing a case. Yes. So every journal, if you try to publish a case report, is going to want patient consent. So if you think you're going to write it up, get patient consent. A lot of journals already have the forms for you, but I think as long as you draft up anything, it's fine. A lot of times you can avoid patient consent too if you hide like identifiers, if you don't put pictures of them, avoid using age. Or if you're going to use picture of them, you can black out things like their face, and just show lesions. But yes, B&J does require patient consent. Some journals are stricter than others, but it's avoidable. But always try to get patient consent, of course.
Hey, Mike, I have a quick question.
Yeah.
As someone that's like starting intern year and, trying to get case reports done, find them, things like that. Did you have like a process where you kind of reviewed your patients for the week and say like, what did I have interesting? Like, how did you kind of, separate that time to find stuff?
Yeah. So at least for us, we have Cerner, at least in our institution. We are able to create like our own list, like under my own name for patients. So it gets busy, I know. So we'll have like 16 patients a day in total in our teams. But towards the end of the week, I'd have in my list, my personal one, I just throw on names of patients like, oh, that might be interesting. That might be interesting. That might be interesting. And I'll add them to the list. And And then whenever I have time, I just go into them and I see which one is truly you can write up. That's something that we do at our institution. I don't know if when you start residency, if you'll be able to do that, but write it down. Write down MRNs. Keep a tracker. Make an Excel sheet. Write it all down, and then just build things. And then when conferences come up, whether it's like cardiology conferences, GI conferences, you look through your list and say, "Man, now's the time for me to write this up and submit it." That's what we did.
Gotcha. Thank you.
Yeah, man. Good question, though. In average, how many case reports should I publish during internship? Okay. Joseph, I don't know if there's a number. It depends on what you want to do. I think a handful of case reports are fine, as long as they're manuscripts, they're in good journals. Definitely, you don't want to have a resume of just case reports. I think you want to expand, do some observationals, some reviews. But I've seen fellows with just case reports, so it's hard to say. It depends on your goals. I think there's always a spot for anyone anywhere. It's hard to say a number. I think if you give me more details of what you want to do, maybe I can give you a better answer. I have a question about references. Can you explain more about how I can find the references for my case? So Walter, whenever you have a case, basically, and you don't know if it's novel or not, the first thing you want to do is go to easy things, just like Open Evidence. You can even go to GPT and just do a preliminary search. It's not a legit one, but at least you can have some things there. After that, you're going to go on PubMed and you're going to do a much better review where you're going to write out, all your terms, and you're going to see and you're going to filter for case reports. That's how you start. If you're seeing reviews, RCTs, observationals, analysis, then it's probably not novel. Now, if you're trying to find citations and references for like guideline deviation stuff, just look at your case and go straight to the society that makes the guidelines. And just look at the guideline for, what they would do in that particular situation. Again, Open Evidence is really good at that. Whenever you guys become residents, or if you are, use it and say, hey, I have a patient with MRSA bacteremia. What are the current guidelines for this? And it's usually up to date. Or at least they'll give you the most recent society like IDSA and see if there's a further updated guideline on that. But I think that's the best way to go about it. Dr. Karasik, from an APD perspective, it's important to keep your focus on being a good intern before you focus on scholarly output. In our program, many interns finish the year without publications at all, and then they pick up as PGY2. Yes, that's true. I think the hardest part about intern year is definitely that. I think a lot of us go through like imposter syndrome, and it's tough. You're staying at work late. You take long to finish your notes. The hardest part intern year is getting research done. That's why I think case reports is the best way. Trying to tackle on reviews and meta-analysis and observationals, intern year is a lot to ask. At our institution, thank God, hopefully, we're very lucky to have a lot of seniors that help out with cases. We take the burden off of our interns a lot. We have very good, culture there, but it's totally right. You need to focus on being an intern. You'll definitely have room second year to produce stuff and do case reports and reviews and whatnot. But yes, intern year, focus on learning medicine. Any other questions, guys? Okay, well, I hope you guys learned a lot from this. And then remember, next week is Journal Club. I'll be sending out another invite, and please email me whatever you guys need from me going forward. I'm willing to help you guys in any way I can. Thank you, guys. And thank you, Dr. Karasik, for all the questions.
Thank you so much, Mike.
Bye.